Cast. A cast holds a broken bone in place and prevents the area around it from moving as it heals. Casts also help prevent or decrease muscle contractions and help keep the injured area immobile, especially after surgery, which can also help decrease pain. The hard, outer layer of a cast is made of either plaster or fiberglass. Cotton and other synthetic materials are used to line the inside of the cast to make it soft and provide padding around bony areas, such as the ankle, wrist, or elbow. Plaster casts can be molded to child's arm or leg. Fiberglass casts are more durable and lightweight than plaster casts. Application of halo-type body cast. The physician constructs this body cast to provide a foundation for a halo in which the cervical spine must be stabilized. This involves use of a torso body cast to which the halo is attached. Casting material is applied tightly, beginning at the pelvis and extending up the torso to the upper chest. Extenders from the halo can be attached to the body cast. This holds the halo very securely. Application of Risser jacket, localizer, body, only. Including head. The physician places the patient face up on a canvas strap tied to a rectangular frame. A stockinette is stretched over the patient from the head to the knees. A metallic half circle carrying a movable jack with a metal plate to be directed toward the apex of the angulation of the ribs is suspended beneath the frame. The jack is turned so that it presses the plate in a direction on the rib angulation that corrects the scoliotic curvature. A second jack may be applied to correct a double primary curve or a secondary lumbar curve. The cast is applied in sections while traction is applied to the head with a hadder and the pelvis with a pelvic belt attached to the plaster girdle. The casting begins with a well-molded neck and shoulder section and finishes with incorporating the trunk. Application of body cast, shoulder to hips. Including head, Minerva type. Including one thigh. Including both thighs. The physician applies a body cast, shoulder to hips. The physician applies 2 layers of stockinette to the patient's torso, armpits to hips, adding cotton and felt padding over bony prominences. Fiberglass or plaster cast is applied over the stockinette to create a rigid cast. Application, cast, figure of 8. Plaster Velpeau. Shoulder to hand, long arm. Elbow to finger, short arm. Hand and lower forearm, gauntlet. Application, cast, finger, e.g., contracture. The physician extends a synthetic stockinette from the proximal interphalangeal, PIP, joints of the hand to the wrist joint and cuts a hole for the thumb. The physician covers the gap at the thumb MCP joint by splitting the thumb tube to extend it proximal to the MCP joint. Synthetic cast padding is wrapped to cover the cast area 2 to 3 layers thick, with extra layers at the proximal wrist to protect the wrist joint during flexion and extension. The physician uses 1-inch or 2-inch casting tape to wrap the hand and thumb in a thumb spica. The wrapping starts with one full around the metacarpals and wrapping the tape around the thumb and hand in a figure 8 pattern, alternating the direction of the wrap around the thumb. The free ends of the stockinette are tucked under the second layer of wrap. Application of hip spica cast, 1 leg. 1 1/2 spica or both legs. The physician applies cast padding to the lower torso and hips and extends this down the affected leg. Indiana 29305. The hip is placed at the desired angle and casting material is placed over the padding material and allowed to dry. Application of long leg cast brace. The physician places a metal or plastic support on either side of the knee. Casting material is applied over the supports to hold them in place. The cast allows the knee to bend and straighten while stabilizing the knee during side-to-side movement. Application of cylinder cast, thigh to ankle. The physician applies a cylinder cast from thigh to ankle. The knee is positioned at the desired angle. The cast and material are applied and allowed to dry.